With me is Marvin Goldfried. He's a very influential psychotherapist and writer, a distinguished professor at Stony Brook University, and co-founder of the Society for the Exploration of Psychotherapy Integration. Your research on the processes of change in psychotherapy, comparing different theoretical orientations for both common and unique factors, helped to catapult the integrative psychotherapy movement, and it's now pretty well established nowadays. So there are still some old and new challenges in psychotherapy research and practice, so it's great to have an opportunity to chat with you about that. Thanks.
Thank you for a wonderful introduction and for acknowledging that we will never run out of challenges.
Quite
Which
right.
is very good, because if we do, then we're in serious trouble.
Well, I don't think we have a shortage on that in psychotherapy.
That's correct. Yes.
So, I'd like to start off with, before jumping into the psychotherapy integration part and nowadays, to know a little bit more about you. I know that at the time you started psychotherapy training, most of the programs were either psychoanalytic or client-centered. And I also know that at the time you read a book by 𝗔𝗯𝗲𝗅 that had a big impact on you. Can you tell us the story of reading this and other experiences that sort of helped you into this integrative path?
Right. Well, I sometimes say that in graduate school, which was at the University of Buffalo in the 1950s, I received a schizophrenic education. And what I mean by that is not necessarily in a pathological sense, but rather I would get very, very different messages. In my clinical courses on therapy and assessment, and a lot of the assessment at the time were projectives, statements would be made with no justification, no empirical justification. It was the opinion of the person writing. But at the same time, I was taking courses in learning and perception, research methodology, and we were taught that if something is going to be entered into a body of knowledge, there should be some empirical basis. So that was my schizophrenia. The Rorschach books and the psychotherapy books, which were mostly psychodynamic, had no references to research. So, and this created a lot of problems for me as to how to reconcile this. And I guess the Dahlen and Miller book provided a very nice bridge in the sense that it was a translation of psychoanalytic principles into learning theory based on learning research. So it was a very, very interesting way to tie the two together. And this appeared in 1950, before behavior therapy came on the scene. And then when it did, in the I guess it was in the late 50s, early 60s, there was a program on Long Island, New York, Stony Brook University, that was setting up a clinical program that would be based on learning theory. So this was a dream come true. So the Dahlen and Miller was the appetizer, and being at Stony Brook, which I've been at for many years now, being at Stony Brook and starting up a clinical program with Krasner and Davison and 𝗔𝗹𝗲𝘅 and others was the main course. And so that was very, very interesting. And then one of the things that happened is that we had a visit from the American Psychological Association that was needed in order to certify our program. And for the most part, I was teaching the psychotherapy class, and it was primarily behavior therapy, and then it evolved into cognitive behavior therapy. And they said they would not accredit us because it was too narrow, so that we should be dealing with all forms of therapy. So what I did is I went back to my graduate school notes and textbooks and readings and marginal comments, and it was very, very interesting. Although I was very, very much opposed to this at the outset, it was interesting in that I began to see some similarities between what people from a psychodynamic point of view were saying and what people from behavior therapy and CBT were saying, using very, very different language. And it was that led me to the notion of well, we seem to be talking different languages. We are not talking to each other. We both have a similar goal of developing a way of understanding human behavior and how certain problems could be dealt with. And our efforts, though, are being set in parallel paths rather than converging paths.
Yeah. And I know, so you're talking about mainly the inclusion of psychodynamic, psychoanalytic ideas to your behavioral insights that you were researching on. But I also know that you went to visit Esalen Institute in the late 70s. Was this an experience that made you first in contact with the more experiential Gestalt side of therapy?
Yes, it did. And other people have done somewhat similar things. Morris Parloff, who was a very key figure in research on psychotherapy, who probably is not known very much to contemporary professionals. He was a central person at the National Institute of Mental Health. And he and some others had written about similarities between behavior therapy and other forms of therapy. And he had ventured into Esalen and all kinds of other things. So I guess he served as a role model. And the interesting thing was that there was a conference in the 70s on behavior therapy in San Francisco. And I decided to use that as an opportunity to go to Esalen Institute for a week. And Esalen, as you may know, is where Fritz Perls did a lot of his work and developed Gestalt therapy and other forms of experiential therapy.
Go ahead.
Okay, and it was an interesting experience, very, very different in many, many different ways. The key issue that came out was the important emphasis on emotion. I would say that the vast majority of things that were going on did not resonate very much with me. Talking about auras, body auras, and talking about the importance of pyramids and putting things under pyramids to save them, to preserve them, so that the idea was if you wanted to use your razor blades forever, you keep it under a pyramid because they're important. So there was a lot of that, but there was also the emphasis on emotion that I had not seen in behavior therapy or in CBT. And CBT, I guess, I'm not quite sure when that came into being. When Jerry Davison and I wrote our book, we wrote it in 74, 75, it was published in 76. We didn't call it behavior therapy. We had no name for it. So I guess it was not until after that, in the late 70s, that the label of CBT came into being.
We'll have a chance to talk a little bit about this importance of emotion, because I know it's also a big part of your work and you helped to bring this into the CBT tradition. But just before going that, I was curious to ask you, how did your colleagues react at the time when you were starting to integrate these ideas?
Well, this is an interesting thing. The way it started, and this was, I guess, must have been around 1980 or so. There were a lot of like-minded colleagues. Paul Wachtel, Morris Parloff, Barry Wolf, Hans Strupp. Many people were saying, maybe we should be looking at the similarities. So Hans Strupp and I spent a weekend together. I went to his university and his house and stayed with him, and we had very long discussions. And basically what he said was, yes, he was a critique of psychodynamic therapy, feeling that it needed to be more empirical. So he was very interested in behavior therapy and came to the behavior therapy meetings. So there were a lot of people within an orientation that felt that more needed to be done. So there was a lot of support for that. And then when I moved, I stayed at Stony Brook, but I moved into the New York City area. Paul Wachtel, who teaches at City University and lives in Manhattan. He and I would get together and talk. And we went through our correspondence and we developed a list of names of people who might be interested in, and then wrote to them. And that's how 𝗷𝗍𝗍 came into being.
Yeah.
There was some opposition, though. Interestingly enough, a former graduate student, Terry Wilson from Stony Brook, was president of the behavior therapy organization and devoted a lot of his presidential address to what I was doing and how bad an idea that was. So it was a very awkward and embarrassing talk, as I recall, sitting there. It's like, how, you may think this, but don't devote your presidential address to this, which he did. I don't know if that was ever recorded.
Yeah. What do you think?
But it was interesting to go back.
Yeah. What do you think were the main arguments or concerns criticizing?
I mean, there was when behavior therapy came on the scene, it was not only an attempt to link psychotherapy to an empirical base, but also to show how much better it was than psychodynamic therapy. So the articles written in the 60s and early 70s had a certain formula. The first paragraph was to talk about the psychodynamic notions with regard to the particular problem or issue that was being discussed in the paper. And then the second paragraph was to trash it and talk how ridiculous it was and how behavior therapy was better. So in many respects, it was a manifestation of that. There was a great deal of antagonism. There was antagonism both ways when behavior therapy first came on the scene.
And this trend. And this trend even moved into cognitive therapy, because even Albert Ellis and Aaron Beck were former psychoanalysts. So even they had this tradition to differentiate themselves.
Yes, that was later already. I'm thinking of the early phase precognition, which was 60s and up to mid 70s or so. And then from the late 70s and on, then what happened is that many of us in behavior therapy, like Donald Meichenbaum and Arnold Lazarus and Mike Mahoney and Jerry Davison, Tom 𝗔𝗍𝗍𝗅, several of us felt that we needed to bring cognition in, because we had, at Stony Brook, we had set up a clinic that was going to be used by graduate students once we developed a graduate program. So prior to that, the faculty was actually doing the therapy. And it was very, very clear that in many instances, behavior therapy was not sufficient. As we put it at the time, there were criticisms by radical behavior therapists that people don't think. And our recourse was, they don't think, they just think they don't think. So there was a battle within behavior therapy, just as there was a battle between behavior therapy and psychodynamic, between behavior therapy, radical behavior therapists, and people who felt that cognition should be included. And then what happened is we joined forces with Ellis and with Beck, and gave presentations at conferences, started a journal, and there was a melding of the two.
Okay, so moving on to your own ideas, in the 1980 you wrote a very influential paper where you argued that rather than looking in terms of techniques and theoretical jargon, there will be a middle ground, the common principles of change that run across different models of psychotherapy. This is one of the quintessential integrative ideas, so I'd like to ask you to walk us through a very I think for me very useful heuristic that you use, that are 4 basic steps you talk about for common strategies. You talk about unconscious incompetence, conscious incompetence, conscious competence, and unconscious competence. I know people listening must be a little confused right now, but can you talk a little bit about this?
Well, I have to confess, when I present this, I sometimes get confused myself. all straight. Basically, that was a later manifestation beyond 1980, but it basically is the philosophy is the same, that we are never going to get agreement at a theoretical level. It's just very, very hard. Within a given school of thought, whether it's psychodynamic, experiential, CBT, there are differences in theory. People have different notions. So at that high abstract level, it's very, very hard to know what goes on. At the technique level, there are hundreds, if not thousands, of techniques. And while some of them may look similar, like role-playing within Gestalt and role-playing within CBT, their function is different.
Yeah.
So I think it's better to look at a higher level of abstraction between theory and technique, the function of various things that a therapist does. And basically, it's the strategies or the principles that they do. And if we look at that level, and this was something that occurred to me as I began to expand the curriculum of the therapy classes at Stony Brook, looking at other orientations. It looked to me that on the basis of clinical observation and some research, there were some common principles. The common principle, before getting into the common principles, let me refer to the conscious and unconscious competence. So basically, a client or patient comes into therapy because their life is not working, and they don't know why it's not working, or they have notions as to why it's not working that maybe are incorrect, but they're not being competent in their functioning, either professionally, occupationally, personally, in various other domains. So they are not competent, and they don't know why. So we can call that unconscious incompetence. So they come into therapy, and one of the things that therapists try to do is to help them understand why they are having the problems. And this can be done in different ways according to theoretical orientation, but basically it helps them to become more aware of factors in their life that are causing problems. So for example, they may have interpersonal difficulties because they are unaware of the negative impact they are making on other people. So they may be thinking other people are mean because other people are not responding well to them, but they're unaware that the people are reacting to them. And what they see as meanness in others is really a consequence of how they are treating the others.
Does this for you have any relationship with the stages of chains of Prochaska?
Well, let me hold off on that. That's an important question.
Okay.
And I will get to that because that's very, very important. So what happens is that therapists, regardless of their orientation, tries to get them to see things in a different way. So they go from unconscious incompetence to conscious incompetence, and they know why they're having problems. The next thing that needs to be done, and of course, clients obviously see this. Now that I know what I'm doing wrong, what should I do differently?
Yeah.
And then the therapy tries to focus on how they can be more effective in their interpersonal lives, to do things differently, to maybe instead of being angry at somebody else because they anticipate the other person is not going to give them what they want, so that they accuse the other person. They don't get what they want. They see the other person as mean, but now they see the other person as reacting to what they need to do, so they need to behave differently. And it may not just be a simple change in behavior. It might need to be a change in perception. It may need to be a change in emotion, so that they behave in a more competent way. And it requires effort. It requires risk-taking. And that is a stage of competence, conscious competence. So they are deliberately doing things in a way that seems to make sense to them, and hopefully it will work better.
Yeah.
And then the more they do it, if the therapy is successful, the easier it becomes, the more automatic it becomes, and then it becomes unconscious competence. Okay.
Yeah.
Right.
So, and you were going to relate to this, or we were thinking about how does this relate to the stages of change?
Yes. The 𝗔𝗯𝗲𝗅𝗍𝗂 model, and the order of authorship varies in the multitude of publications and research that they've done, focuses on a broader time spectrum. So they are talking about what goes on with an individual even before they enter therapy, whether they're contemplating change or not. What I've been talking about is what happens when they begin therapy. So that's one of the factors. The other factor is their stages of change refer more to what is going on within them, whereas the stages that I'm talking about are more guidelines for a therapist, of the therapist to know what they need to do at the various points. That it's too soon to try to change the person because they are not necessarily aware of the problem that is causing. They're not aware of what is causing the difficulty, and they should probably be aware before they start to change. So it's more of a guideline for the therapist.
Yeah, and it's a guideline that can apply to any therapist of any theoretical orientation.
Yes. And it's still at a very general level of abstraction.
Yeah.
But it's a starting point. So within that starting point, we can talk more specifically as to what needs to be done in order to get the person to move from unconscious incompetence to unconscious competence.
Okay.
So the principles of change, the person has to come with a certain level of expectation that change is possible, and that they have an appropriate motivation. And of course, this is a major challenge to many therapists when somebody is forced into therapy, such as the partner in a relationship is told, you better get into therapy, otherwise our relationship is over. Or a parent tells an adolescent they have to be in therapy. So that is necessary, but not a sufficient condition. The expectation and motivation. There has to be a good relationship. Much to my dismay, there are some young CBT therapists that feel the relationship is really unimportant. I think it's terribly misguided. Many people will not come for a second session if the interpersonal connection doesn't exist. And I tell my beginning graduate students that the goal of session 1 is session 2. And thereafter. So the therapy alliance becomes very, very important. And there's research to show that if the alliance is in place by a certain early portion of therapy, session 3, session 4, it increases the likelihood that there'll be a success. But it's more than the alliance. So what needs to happen, and this maps on to going from unconscious incompetence to conscious competence, therapists of all orientations need to help increase the awareness on the part of patients. We as therapists are attention redeployers. Somebody will not pay attention to the consequence of their behavior, or to the link between their behavior and the behavior of somebody else. They're paying too much attention to the person and conjuring up, trying to understand why that other person is so mean to them, so ungiving. So they need to redeploy their attention. They need to redeploy their attention to realize that when they're angry, they may be quiet, and that may have an impact. They need to realize when they have certain thoughts, there are certain emotions. They need to realize many of these different connections. So increasing awareness is something that we do. We may help a client or patient become aware of different things depending on the nature of the case and depending on the nature of our orientation. But hopefully, we are correct in in pointing to the right factors that they need to become aware of.
Mhm.
And then at some point in the therapy, they need to behave differently. That's the conscious competence. And Alexander and French spoke about the corrective emotional experience. So I think of it as the corrective experience because it's the corrective behavioral experience, the corrective emotional experience, corrective cognitive experience. It's doing things differently. And why would they do things differently? Well, because they're motivated and they expect change, because there is a therapeutic bond and they trust the therapist and they want to please the therapist, because they become better aware of certain factors that are causing problems in their life. So they do things, and if what they do is indeed effective, it will work and it will reinforce them. It'll reinforce them because people will give them what they want. They'll be less angry. They'll feel better about themselves. So there'll be many, many factors. So we have that increase. We have the corrective experience. Facilitating a corrective experience is a principle of change. And then we can think of having ongoing reality testing, which occurs over a course of therapy. The person goes out and does things differently, then comes back to the therapist and talks about it and processes it and understands it better. And that processing and understanding hopefully will increase the likelihood that they will continue with more effective behaviors. So in a sense, the ongoing reality testing involves both increasing awareness, leading to corrective experiences, resulting in increasing awareness, which in turn leads in a more synergistic way, hopefully, to change to unconscious competence.
Which is what's very interesting to me about this path that you've talked about is that it's specific enough to help conceptualization and intervention, but it's broad enough to be able to each therapist bring in their own theoretical biases.
Or formulations. But here's the interesting thing about this. So the way the procedures, the clinical procedures that we observe when we watch a video of a therapy session can be thought of as parameters of the strategy or principle, can be thought of as testable parameters. So rather than using intellect and strength of logic and persuasion or aggressiveness to convince somebody from another orientation that your orientation is better, this can be put to the test. So you cannot just use the principle alone. You cannot tell a supervisor, go in and increase awareness. Increase awareness about what? That certainly is based on case formulation.
Well, you just touched on a point I would like to move into. You ask increase awareness about what, and your work has expanded that what in cognitive behavioral therapy, or helped expand to emotion. We talked a little bit about this. So I know you have been critical about the lack of emotional awareness and attention to emotional processes in psychotherapy. And you were one of the early cognitive behavioral therapists who wrote about the importance of emotion. And you also studied how different orientations seem to deal with emotional arousal in therapy. What lessons can you share with us about the importance of emotional arousal in therapy?
Okay. I published a paper in 1974 on cognitive restructuring, calling it rational restructuring. And this was influenced to a great extent by the work of Albert Ellis. Now, for people who don't know Ellis was a very outspoken therapist practicing in New York. It was at the Institute for Rational Living, and then he kept changing the titles. It could have been emotional, it could have been behavioral, depending upon what seemed to be popular at the time. But he would tell people, you're stupid if you think this way, stop thinking this way. And my sense at the time was that this was really not getting at the thoughts, or this was not necessarily a good way to change the thoughts. Because sometimes, I remember this is 1974, so my thinking at the time was, well, it wasn't as if people thought everyone must love me, or I must be perfect, but they behaved emotionally and behaviorally as if they thought that.
Yeah.
So
it was pre-verbal in a sense.
It was
symbolic.
Well, it was unverbal. I don't know if it was pre-verbal. At the time, it was as if. So there was something there, and I'm not quite sure if at that time I was starting to talk about schemas in '74, but it wasn't shortly after. It was shortly after that. Since that time, there's been much more written about this. Kahneman and Tversky have written about it. Seymour Epstein has written about it. John Teasdale has written about it, of dual processing systems. There is and different parts of the brain that are involved in the processing of these things. So a wonderful example is the meaning of springtime. Spring is and this is an example given by John Teasdale. The propositional meaning of spring is that it occurs at a certain time in the year. The days begin getting longer, temperature gets warmer, buds come out in trees and flowers start to bloom. That's what spring is. However, there's another meaning to spring. It's which he calls the implicational meaning of spring, which is a change in mood, a feeling of optimism, a sense of freedom, of rebirth.
So symbolic meaning.
It's symbolic in a sense, yes, although it's a tricky word to use because you will shut down the listening of certain people when you say that. But it conjures up affective meaning, and it may be that the learning of this didn't come in the lecture of life, but came in the lab of life.
Yeah.
So it could be a different kind of conditioning that is involved. And that is the kind of, quote, cognition or thinking, the as if, the schema, the implicational meaning, that gets people in trouble. So what you need to do if you're going to do cognitive restructuring, which is an easy thing to say in CBT, I'm going to do cognitive restructuring. What kind of cognition are you talking about? You're talking about implicational meaning. So you need to get the implication, you need to get the emotion simulated in the session. And this is a lesson that I originally learned at Esalen, and then learned later on by talking to experiential colleagues in my interactions with Les Greenberg over the years. The importance of emotion in a certain kind of meaning that people apply to life situations that is clinically relevant.
So.
But the history of CBT versus experiential or even psychodynamic is very different. So we did a process analysis, Susan Weiser and I, of psychodynamic therapies and CBT therapists. And we found that when they sent in significant sessions, the significant sessions of the psychodynamic people showed an increased emotion during the significant portion, whereas the CBT therapist showed a decrease in emotion during the significant portion of the session. And I think here we're talking about different kinds of emotion. I think CBT people think about emotions as problematic symptoms to reduce, whereas experiential therapists think about emotions like primary emotions as a way of increasing meaning and increasing awareness of other things that are problematic in a person's life.
Adaptive emotions.
What?
Adaptive.
Adaptive emotions, or even maladaptive emotions, such as anger at a caregiver, chronic anger at a caregiver, such as in complicated grief, and having that anger lead to the recognition of the frustrated need the person wanted, and then becoming better aware of why that need was not met, either because of circumstances on the part of the caregiver, such as I was a single mom and I had 2 jobs, or because of some other characteristic. But I didn't get what I wanted, not because of me and being a bad person, but because of either circumstances in my caregiver's life or because of their characteristics, which is unfortunate. So, and there's process experiential therapy research to demonstrate that this, in fact, does go on and does produce change.
So again, it's a question of flexibility, when to give arousal.
Exactly.
Yeah, when to regulate up or down the emotion.
Absolutely. Yes.
What about
and that is one of the wonderful things about integration.
It gives you both ways.
because the tunnel vision, if you will, of a given orientation can complement the tunnel vision of another orientation.
Of course, yeah.
Yes.
What about the therapist's emotional arousal? I'm not familiar with any research relating therapist arousal, emotional arousal, and therapeutic outcomes. Do you have any take on that?
Are you referring to the book that we recently published?
No, did you?
Yes, this is Wolf, Goldfried, and Moran.
You have it there?
Let's see if this works.
Is it out already?
Oh, yes.
Yes, from frustration to compassion.
Yes.
Yeah.
This is like a TV program where
By now.
by my book.
Exactly.
Yes, and this is a tricky kind of thing because there are some naive CBT therapists that say, oh, this does not happen in CBT therapy because it's the technique that's powerful.
Okay.
Well, it does happen, and there are data to show that it does happen. And there are data to show that it often happens when the therapy is not going well.
Yeah.
Where the excuse me, where the therapist feels frustrated. And in doing supervision with graduate students, they don't openly acknowledge it, their frustration. So it becomes very important for them to become aware of their reasons for the problem that they may be having. Because if the therapist has a negative reaction toward the patient, and if that shows itself, there are data to show that not only does the therapy not work, but the patient can get worse. So this must be dealt with. You don't have to call it countertransference. You can say there are research findings to show that this needs to be attended to.
So emotional awareness on part of the therapist.
On the part of the therapist, and in supervision, this is a gradual kind of thing that happens, and the supervisor needs to pick up on that. Yeah.
I'm sorry, but you're talking. I'm making this link now with another area that you have written in the recent years more and more, which is the gap that exists between research and practice in psychotherapy.
Yes,
Is this like a bad marriage where researchers and clinicians just don't seem to want to hear each other out?
Well, to a great extent, it's not even a marriage. And often they're not even dating.
So that's the first problem.
Yes. No, there is a history within certain schools of thought, psychodynamics certainly, which is not necessarily research oriented, and certainly in the experiential school of thought, research is not valued for the most part. I think the work of Les Greenberg has been an international game changer here, but Pearls had spoken not only against psychoanalytic thinking, but anything other than experiential. And it's a different epistemology. But this gap goes back to what I was saying before in my graduate school days. where there was the gap between the two.
Yeah.
And it's manifested in a number of different ways. There's an antagonism, an underlying antagonism, and sometimes not so underlying between the two. Whereas the researcher will decry that the clinician is not reading the literature and that, they're incompetent. And the clinician will say the researcher is not studying what I need to have studied.
Yeah.
And that's where we developed this two-way bridge initiative, two-way bridge, closing the gap between research and practice through APA divisions of clinical psychology, Division 12, and psychotherapy, Division 29. And there is a website that people can go onto, and it's www.stonybrook./edu. Somewhere in there is, I'm not quite sure where in the URL, it's a two-way bridge, or you can just go online to Google two-way bridge Stony Brook.
Yeah.
And you'll find the website where we have the rationale for it, and also some data on how practicing clinicians have been able to pinpoint certain areas based on their practice that needs research. So it's the dissemination of clinical observation to the researcher.
But you were saying that different traditions seem to value in different ways the research. There are two things that spring up here for me. First of all, the tradition that supposedly is more influenced by research, the cognitive behavior one, seems to recently have not followed so much a broader research in psychotherapy. We have research saying that techniques are not so important as relationship, for instance, or all therapy models are not the most essential part of the outcomes. So what's this blind spot even in this tradition that supposedly cared about research?
I'm not quite sure what the tradition is you're referring to.
Cognitive behavioral. So the cognitive.
Well, there are cognitive behavior therapists that are very much wedded to the notion that it's the technique.
Yeah.
And that research is essential, and underplay clinical observation.
Yeah.
And I do think, that is problematic. I think this is probably true of all orientations, and it's called the notion of the true believer, where they know what they know, and they're very adamant about this, but they don't know what they don't know. So there's only certain literatures that they read, and there are other things that do exist. And that is one of the goals of Society for the Exploration of Psychotherapy Integration, SEPI, to both get dialogue across the theoretical orientations, but also get dialogue between researchers and practitioners. And good researchers, successful researchers, award-winning researchers know that you don't develop a design to study something unless you have reason to believe that it exists, that you've seen it informally, and now you want to control for certain variables to demonstrate. I believe it because I've seen it. Now I develop my research design to convince my colleagues that it exists. And I think that is good research, and that requires both clinical observation as well as research design.
Yeah, and this is part of the broader mission of SEPI, as you were saying.
Absolutely.
Yeah, we're moving into the last phase of our talk. I'd like to ask you about a different thing, which is also related to the research, which has to do with therapist effects. So recently, there has been evidence that therapist characteristics have more impact on the outcomes than any particular type of treatment. And because of this, Michael Lambert has said that we should encourage research focused on empirically supported therapists. With the current research, what do you think will be the defining features of these future empirically supported therapists?
Well, that's a very complicated question. because there's a lot behind it. First of all, yes, therapist effects are important sometimes. And yes, therapist effects are unimportant certain times. So there's a lot of online intervention research to show that the absence of the therapist and following certain therapeutic guidelines can produce changes for certain individuals.
Yeah.
So the question becomes not are there therapist effects that are important, but under what conditions? So if it's a simple problem and the guidelines are, if a person has a simple phobia, very specific phobia, that could probably be put online.
Self-help.
With self-help. I believe it can.
Yeah.
Peter Lang some years ago did that in a very low-tech way. He had two tape recorders. One tape recorder was giving the exposure to the anxiety-producing item, and the other tape recorder was giving relaxation instruction. And he called his device the device for automatic desensitization, affectionately known as DAD. But therapist effects are clearly important. So I can be supervising somebody and a graduate student and see the case, and it's like, this person cannot handle this case, does not have enough experience. So I think the question is the therapist effectiveness has to do with clinical experience, and there are some data, not a lot of good data on this, that the more experienced the therapist is, the more they have encountered in their clinical experience, in their readings, in their life, they know more. They have more hyperlinks. So if a patient says something, I already know this, then that word know could be, maybe it is propositional knowing, not implicational knowing. So there are hundreds, if not thousands, of hyperlinks that the person can develop. I think some of this can be put online and trained with training videos, so that the experience, the common experience of experienced therapists, can be articulated in some way. There are some therapists that are better than others, and there's research that is indicating that. So I don't. People are much too complicated to make blanket statements the way some people do. Therapy is much too complicated to say, here is the answer.
Yeah.
And I think we need to look more at the specifics, the mediators and moderators. And I think that is starting to happen. There's a greater recognition. And many years ago, it was Gordon Paul who said, and I don't remember the exact quote, but it was, with this particular client, under what conditions, with this particular problem, would be the most appropriate intervention.
What treatment for whom, under which circumstances?
Right, that's right.
Yeah.
One size does not fit all.
So with that note, I would like to give you one last question that I have been asking everyone I've interviewed.
Yes.
What is the advice you wish you would have received when you were starting out as a psychotherapist?
That this is very hard to do, because it's going to require a lot of experience. If you needed surgery, would you go to a beginning surgeon or would you go to an experienced surgeon? Things happen. In simple cases, you don't need that. But in complicated cases, there's a lot of clinical decision-making that has to be made in real time during the course of the session. And the making inappropriate comments or missing certain kinds of things can be very, very problematic. So be patient with yourself.
So from frustration to compassion, again.
Yes, exactly. Except with yourself rather than...
Yeah.
Exactly, yes.
Marvin, it's been such a great pleasure. Thank you so much for
I enjoyed this, Alexander. Yes.
And I hope we'll be able to talk soon again.
Very good. Thank you.
Goodbye.